Hello, everyone, and welcome to today's virtual panel discussion brought to you by the Georgia Association of Healthcare Executives. My name is Ricardo Rivera, and I'm your session host representing the National Office of the American College of Healthcare Executives. Before we get started, I'd like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session unless there is an active discussion, at which point you may unmute yourself to talk. You can submit questions through the chat function at any time. This event is being recorded and will be available for viewing in ACHE Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 face-to-face credits applied within 2 weeks from today's event. We do encourage you to complete the evaluation for this event. The evaluation link will be posted in the chat box soon, so please visit the link before we close out today's session. Now, to begin the session, let me turn it over to Trent Litt, GAHE President. Trent, I'll turn it over to you.
Hey, thank you, Ricardo. And welcome, everyone. Excited to have a great group today here to attend a tremendous session. The topic, obviously, sustainability of healthcare organizations, leveraging data and technology. I think we've learned quite a bit, especially in recent years, around how we leverage our data to improve our processes and systems. And so we're really excited to have this opportunity to share with you and have really, again, a panel of experts that are with us today. So certainly thrilled to kick things off today. And again, here's the topic for you. And again, I want to thank ACHE giving us the opportunity to have these face-to-face credit opportunities with our membership. We've been hosting these events now going on a year. Virtually and face-to-face really for the past 9 months, and have had just an outpouring of positive response and success. We can't put these types of events on without amazing sponsors, and our platinum sponsor, Wellstar, has stepped up over the past couple of years to serve as a platinum sponsor for GAHE, and so thank you so much to Wellstar. And also our other level sponsors you can see here, Gold Level, Cancer Treatment Centers of America, Sound Physicians, Metro Atlanta Ambulance Service, Beck, Protiviti, Philips, HCA TriStar Division, and our silver sponsors, DT Spade, KCA Firm, SSR, and Nagel and Associates. Thank you again so much to our sponsors. As you can see, upcoming events that we have on tap, if you will, you can see across the board, April, May, and into June, and really just encourage you to stay connected, have a chance to evaluate and view opportunities for you to continue face-to-face and qualified education hours. And you can register for all these events at gahe.org. Ways to stay connected. Really proud of our communications efforts and marketing efforts with GAHE, led by Steffi Browning and her communications committee. And you can see here just a lot of different outlets. One, obviously, our gahe.org website. You've got our Facebook there as well as LinkedIn, and then also obviously Twitter. All different outlets where you can stay connected to the great events and that we're putting on in educational sessions. And get involved. This is our shameless plug that we ask members that are not as involved as you could be, reach out to us. You can see here at admin@gahe.org. That email address will go directly to Bruce Lloyd, our executive director of GAHE. And whether through these various awesome committees, communications, career development, fellowship advancement, member growth and satisfaction, diversity and inclusion, physician executive group, programs and sponsors, all different ways you can get involved. And again, a reminder, you get an hour and a half of face-to-face credits. Make sure that you're signed in and ready to go. These credits will be added to your record. Allow 4 to 6 weeks for that to take place. All right, now without further ado, today's program, again, a tremendous topic. We've got really a highlight group of panelists. You can see here Pam Arlotto, as well as Dr. Knight with us. But I'm going to have Matt Enright present, and I would like just to share a few words about Matt. Matt's the project manager around value-based care within Piedmont Healthcare. He's also an active member of our GAHE group, and really appreciate Matt's support. I'm going to read a little bit about Matt, who you can see on the screen, but Matt is passionate about helping healthcare organizations drive business value by increasing efficiency while simultaneously improving quality and safety. He partners with C-suite and physician leaders to realize their vision by creating practical strategies and tactics to ensure measurable results. He leverages his experience in consulting, change management, systems engineering, Lean Six Sigma, information technology, and analytics to guide cross-functional teams to solve some of the most complex problems facing healthcare today. Matt is an adjunct professor at Mercer, teaching Lean Six Sigma to MBA students and professionals. He is currently facilitating Piedmont's value-based care leadership team to update our strategy to leverage current strengths and is responsive to this rapidly evolving market. Matt is leading a system-wide project that uses predictive analytics to forecast preventable emergency department visits and inpatient admissions. The output of this project will be assigned to clinical team members to proactively reach out to patients and bend the cost curve for preventable visits. Matt's an active member of GAHE's programs committee and has moderated several programs for us. So he's a pro here. So I'm going to turn it over to the professional. Matt, thank you so much for moderating our session today.
Trent, thank you very much for that gracious introduction. I'm going to switch PowerPoint slides. And okay, can you guys see my PowerPoint? All right, great. Thank you again, Trent, for that introduction. And welcome to everyone here about a great topic today, sustainability of healthcare organizations leveraging data and technology. I want to cover a couple things here. We're going to use Zoom polling throughout this session, a couple of questions, just to keep everyone engaged. I think will also help our panelists, our esteemed panelists, tailor their responses to some of the questions that we're going to talk about today. And also, please, as it mentioned in the chat, please send your questions in there. And at the end of the session around, we'll do the Q&A session and pull questions from there. So please go ahead and, as you think of questions, go ahead and put them in there. So I'm going to Zoom poll the audience really quickly first. We want to get a little idea of who's here today. So what's your role in the organization? Take a few seconds and respond to your role. And got some responses coming pretty quickly. So another second or two. All right. I'm going to share the results. So again, Dr. Knight and Pam, take a look at who's here. We've got, a couple physicians, some nurse leaders, non-clinical leaders, consultants, vendors, and others. So you get an idea of who's here in the room. All right. I'm going to stop sharing those results. I've got one more poll I want to run to again. Again, as it relates to leveraging data and technology, how would you compare your organization to your peers? Are you way behind, somewhat behind, in line, slightly ahead, way in front? Give it just a few more seconds and we'll close the poll. And all right, let's see. Here's where we are. I think generally, people are either in line with their peers or they feel slightly behind is the general consensus. So again, Pam and Dr. Knight, keep this in mind as we go through the discussion. So I want to cover sort of our learning objectives for the discussion today, what we plan to cover. We want to really talk about how do we simplify efficiencies across an organization by leveraging technology and data. What are the workflow needs of healthcare providers in the digital era that can best be served to maximize quality, safety, and efficiency? We'll talk a little bit about common technology and process challenges that can hinder sustainability, and also how to engage key stakeholders in the design and execution phases. as well as some key takeaways. We really want this to be practical so that you can take some of the lessons from today and apply them at your organization. So that's sort of the focus for today. All right. So why is this so important? Really, because healthcare has to do different things differently to be sustainable. And here's an example project that I'm currently leading at Piedmont. We're using a proof of concept around predictive analytics to try to predict who will end up with the most preventable ED visits or admissions this year. And it's a really important question. The model that we're using, we fed it 1 million patients with 139 different variables. And it ran through 66 different models. And it picked one out of those 66 models to actually say this one has the highest predictability of that question, who will end up with the most preventable ED visits or admissions this year. I ran it against some of the clinical team members, completely independent from the project, and the results they reviewed were 95% accurate in its prediction. So we think this model is a really good model that we can use going forward. And I'm partnering with care management to figure out how do we proactively engage these patients to make sure we get in front of it. We're also obviously working through an ROI model, which is very important throughout our organization. So that's still going. This is an ongoing live project today. Really exciting stuff, but I really want you to hear from the experts. I just want to share a little bit of why I think this topic is so important today. And without further ado, I'd like to introduce our speakers today. I'm going to introduce Pam Arlotto, who is President and CEO of Maestro Strategies. Pam is a healthcare strategy thought leader. She advises CEOs, boards, and senior healthcare leaders to orchestrate the transition to the next generation of patient-centered connected care. Pam combines her background in systems engineering with healthcare strategy to drive measurable return on investment. Her clinical clients include prominent integrated delivery systems, clinically integrated networks, and accountable care organizations, as well as solution companies, public-private company partnerships, payers, employers, and associations. Pam served as national president of HIMSS. She's also held positions on advisory boards at the Georgia Institute of Technology and Emory University School of Medicine. Pam is currently a member of the Georgia Tech Foundation, is on the board of several privately held companies. In 2020, she authored Orchestrating Value, Population Health in the Digital Age, and previously wrote Beyond Return on Investment, Expanding the Value of Healthcare Information Technology. Pam is a frequent speaker at healthcare industry meetings and podcasts. She's been featured on NPR and the Wall Street Journal. She holds an MBA from Georgia State and a Bachelor of Science in Health Systems from the Georgia Institute of Technology. It is my honor to welcome Pam Arlotto.
Thank you, Matt. So Matt asked me to have a few opening remarks, and I want to start with a framework that we set up several years ago. We actually partnered with what used to be the University Health System Consortium in Chicago prior to their merger with VHA Vizient to create this initial model. And we interviewed CEOs, informatics executives, quality executives, CIOs, and a whole variety of other executives to look at what were the skills and competencies and capabilities that were going to be needed for the future as we transition from volume to value. And interestingly, even though we developed this model and framework a few years ago, we have found it continuing to be important and impactful in helping organizations and individuals figure out kind of where they are and their progress and the things they need to do to make the transition. We've tweaked it a few times, updated it and modernized it, but I kind of want to go back to your poll answers. So nobody was on either end. So you didn't have a lot of people way behind or way ahead. Everybody was either a little bit behind or kind of in line with the peers pretty much. And what we would say that would put you is somewhere between bricks and mortar healthcare and or involved in the transition. And if you had fully been way ahead, you would have probably been fully innovative, digital health, connected care. But as we all know, the whole industry has ways to go to get there. But just so you understand the model and think about it in terms of your own organization, payment structures are different. We see that middle category being the foot and two canoes, some combination of fee for service and some combination of value-based care. The difference in the way we're organized, very fragmented under bricks and mortar, very siloed, all the way through collaborative consolidation. And the far end, we've got many groups working together to innovate. Other differences in these different stages, if you will. In the middle, we're building out capabilities such as ACOs or new care coordination programs, new capabilities such as analytics, care management tools, interoperability. But I want you to look at the bottom. In the very initial stages, we were building out systems of record, and that would be your EHRs, your enterprise resource planning tools. In the middle, you're focused on building out systems of intelligence. That would be these analytics, care coordination, and interoperability capabilities. And then ultimately, when we really are in a digital health and connected care environment where we have a lot more focus on value, we're focused on systems of engagement. And so keep this in mind as we talk about some of the other questions later, because this framework can be very, very helpful in thinking about the steps and what we need to do to move forward.
Thank you very much, Pam. All right, we're going to go and do one more poll. Again, this will help guide us throughout our conversation today. So, and this you can answer you can have multiple responses. So what areas are you leveraging data and technology today? Again, you can click on multiple options for this. So I'll give everyone a few seconds to respond and share the results. All right. End polling and share the results. Very interesting. I'm encouraged that clinical data is at the top. I mean, we are in healthcare after all, right? But no surprise, financial reporting is obviously in there. Forecasting starting to step up a little more. People are using forecasting. I'm a little surprised, honestly, that RPA hasn't moved a little bit, but I'd love to hear from the experts, Pam and Dr. Knight, later on that. But I know RPA, there's a lot of talk about it. There's a lot of use cases here in the healthcare field. But again, I'm going to ask our speakers to keep this in mind as we go through the discussion today. Yeah, stop sharing. And I would like to introduce Dr. Lacey Knight. Dr. Lacey Knight, you still there?
Hello,
okay.
Everyone.
All right, I didn't see your picture. I just want to check. All right, so Dr. Lacey Knight is Vice President and Chief Health Informatics Officer at Piedmont Healthcare. Dr. Knight is an emergency medicine physician with over 20 years of healthcare experience, much of his time working with clinical technology. Epic has played a major role in Piedmont's strategic growth and quality improvement by achieving efficiencies and standardizing clinical processes at each of the system's 11 hospitals and 660 locations. As CHIO, Dr. Knight plays a critical bridge role between Piedmont's clinical teams to provide bedside care and its information services team to ensure communication is effective. For the last 20 years, Dr. Knight worked in Illinois, most recently as Chief Medical Information Executive for North Region and Physician Director of Health Informatics at Northwestern Medicine. He's also worked as an Emergency Services Medical Director, Independent Consultant, and Emergency Physician. Dr. Knight has led many successful EHR and clinical technology implementations. He's board certified in emergency medicine and clinical informatics. In 2015, he earned his Master's of Science degree in medical informatics from Northwestern University. He received a Bachelor of Arts medical degree from University of Missouri, Kansas City School of Medicine in Kansas City, Missouri. It is my honor to welcome Dr. Knight.
Thank you, Matt. And thanks everyone for allowing me to be here. I'm very happy to be participating in the Georgia community of healthcare. So in adding to Pam's comments a little bit earlier, the changes in the needs of the health system, the healthcare organizations, also relies upon changes and evolutions in the leadership structure. So we know that we've had a lot of different changes in patient expectations, in the expectations of the clinicians and healthcare providers. There have been environment changes to healthcare, a lot of competing priorities, and certainly with the crisis of the last year, there have been changes that really forced us to need to look at things differently. And in the evolution that Pam described, there's also been an evolution of leadership roles. And I think many of you maybe know the original orientation, which was a physician that had some bent towards technology, understood the technology, could explain it, and help bring peers along. Really focused on just getting people to use the new tools, and it was a big change. You know, I'm in the age group that spent most of my training on paper, and have specific memory to the first interaction I had with a technology tool in Kansas City, where Cerner Corporation is based, and we stopped going to the medical records room to review charts. We were able to view them electronically, and a big difference that made. So the initial wave of the CMIO was focused on those roles, really just getting people to move from paper and one system to another, which increased the transparency of what was happening to the patients. And as that has evolved, there's been more formal organization related to collaboration with clinical leadership, and trying to make sure that we've built the right teams to help support analytics, gathering information that's going to be used for patient care. Almost everything that clinicians do today to ensure that patients have the right quality, the right direction, the right care now touches technology, whereas when I started, it did not. And so developing those teams was an important part in the transition of where we are today and where we need to be in the future, in roles similar to mine at Piedmont. And this is really focused on the strategy of how to make sure that the organization gets from where it is to where we need to go in the future, to support business objectives, patient care, more distributed options for caring for patients. The virtual health space, I'm sure everyone on the call today has had some role in participating in that in the last 12 months, either as a patient or as on a provider side, and continue to work with the quality departments to look at how our capabilities match what we need to in the future. And I think a key component is really making sure that the right information gets to the right person at the right time.
Great, thank you, Dr. Knight. All right, we'll move over to the first question here. So Pam, the word sustainability means a lot of different things to a lot of different people. How, in this context of leveraging data and technology, how would you define sustainability?
Well, Matt, I'm going to give you 3 definitions because, as you mentioned, it means a lot of different things to a lot of different people. The first one that has to do with this whole transition from volume to value is sustainable healthcare, addressing an improvement in the health status of a population. So that's one definition. Another one's a little more management oriented, and it has to do with all the components of the health system. So you think about it, inpatient care, post-acute care, primary care, specialty care, home-based care, whatever the care, and making sure that we have continuous improvement, innovation of those components and their relationship. One definition that I really personally like, you can use in a variety of settings, and it is about meeting the needs of the present while preparing for the needs of the future. And that can be around a whole number of areas, whether it be economic, social, environmental, et cetera, et cetera. But one thing that is clear, and I did do a bit of research on this just to see what the thinking was, is that value-based healthcare is largely considered the blueprint for promoting sustainable management of health and health care over the next few years. And I think we saw that with COVID, in that a number of the fee-for-service models really let us down when we had to close up shop, if you will. One other point relative to data and technology, as we're discussing it today, what I've seen in our work around the country is that where we run into trouble is where we try to hook value-based care or population health on the old operating model. So those fee-for-service or bricks and mortar operating models, that we really do need a new platform, if you will, and new ways of using information to change and really be able to move forward in a value-focused manner.
Thank you very much, Pam. You described my daily struggle in the value-based care team, trying to explain how this is important and going to be viable, but we're not at the tipping point yet, at least in this market. We're getting close, so
right.
Everyone's got to be ready. So I appreciate that. All right, Dr. Knight, this is probably the understatement of today's session. The pandemic has changed healthcare forever. So what are the new leadership skills needed to be successful in this new world?
Man, that's a great question. And, every time I hear pandemic, I just really am astonished at how remarkable the last year has been in terms of all the efforts necessary to continue to care for patients. Also, all of the, personal obstacles that people have endured. It's really been tremendous. And I think is a good example of how we'll likely be tested in the future. So in order to be successful in the future, I think you still need all the traditional skills that are required for leadership. But I would say that a few things that came to mind that I think would be at the top would be the ability to focus. And what I mean by focus is really know what to stop doing. We all have more things that we can do than what we have time to do. And it's really important that we make sure that the things that we're doing are the most important things that we need to be doing. A second component of that, or related component of that, is really about leveraging data. And because sometimes you're not sure where to focus your efforts, and that's where the data can be actually quite beneficial in helping you understand where you can have the greatest impact, or where you've got the greatest access or opportunity. Is important. A second skill set is really agility, and this is for both organizations as well as in individuals, and it means finding out how to make decisions maybe a little bit faster than what we have before. I think many large organizations can be hampered by a broad consensus-driven structure to make decisions. It takes a lot of time. It can still reflect the priorities of the organization, but we need to be a little bit more nimble in our ability to make decisions that advance the organization. And I think balance the risk and benefit to determine what cohort needs to be involved in order to make that decision. And I think additionally, one of the ways that we've thought about agility is really to plan for it. Piedmont's an organization that has really grown tremendously over the last 5 to 6 years. And which with growth comes a lot of changes, and with changes in healthcare, come additional changes and opportunities. And so what we've tried to do is make sure that we look to develop platforms, governance structure, teams to enable agility in an organization our size. I think the last skill set that I think I'll reference is really about collaboration. This has always been something that we needed to do. I think in many ways we've thought of it as formal structures for collaboration, thinking about well-defined roles and responsibilities, but we need to think a little bit beyond that, and I think look at skill sets that different team members and different divisions within organizations can contribute to collaborating in ways that maybe we didn't consider in the past. One specific example for us has been during the pandemic with our stand-up of virtual health. We had the opportunity to leverage folks from the quality organization as well as the strategy part of our organization to assist in developing some of our virtual health rollouts. So we took people that had strong skill set in one area that we could leverage in order to develop a virtual health platform, and we're able to apply those skill sets to something that was not traditional for them.
Great, thank you. Thank you very much, Dr. Knight. I can definitely understand the collaboration changes that COVID has brought. I was working in the command center at Piedmont during the initial days of the pandemic, and there were team members that I had met in the hallway, but I never worked arm in arm with them. When it came to this true burning platform, we learned to collaborate in very unique ways, and it was really, really powerful. So I think that's here to stay, and I think that's a really, really positive. So thank you for sharing that. Okay, I'm going to go and do another Zoom poll. So, is your organization deploying technology differently than it did before the pandemic? Is it much faster, about the same, much slower, unsure? Give it a few more seconds before we close the polls. All right. Interesting. Much faster is definitely what I've been feeling here. We've done things that we've said we're going to take years and years and years, and we did it in weeks or days. So it is interesting. So again, Pam and Dr. Knight, please keep this in mind as we continue our discussion today. Stop sharing. All right. So the next question is for Pam. In prior discussions we've had, you've shared how important it is to really take a systems view to make sure we can simplify efficiencies. Can you explain the systems view concept a little better and how it applies to leveraging data and technology?
Sure. So a systems view or systems thinking is a problem-solving approach, and it's best used in complex settings. Well, I don't know of another setting more complex than healthcare. But what you do with a systems thinking approach, and it very much fits with what Dr. Knight was describing in terms of collaboration, bringing in multiple skill sets, multiple perspectives and views, but you look at the components of a system and how they interact with each other, not just how they act individually. You consider things beyond the technology if you're deploying a technology. You look at operating models, the processes, the org structures, the job design, the culture. And then you use data to look for patterns and trends so that you can not just base it on consensus, not just base it on, well, this is the way it's always worked. And I think what we've learned, telehealth and his example of virtual care is a perfect example. A lot of people deployed telehealth tools during the early days of the pandemic, but now they're beginning to recognize there are other components of the system if we want to continue to use virtual tools that make a bigger, more complex strategy for virtual care that thinks about all the parts of the system, all the service lines, a whole variety of tools, text, video visits, phone, remote monitoring, but think about how we're going to use it pre-visit, post-visit, how we're going to interact with scheduling. So it's that more holistic, orchestrated view versus just saying, okay, we're going to roll out a new technology. And you can still do that agilely and quickly, by the way, but do it instead of big bang in a more targeted kind of minimal viable way. What's enough, and test it and then iterate the next generation and the next generation.
Thank you, Pam. I see more and more healthcare organizations, providers using Agile in that methodology of bringing things to market faster beyond just in the IS space. I see it at projects looking at it the same way. So I think moving faster is required to be sustainable, and really looking beyond just the traditional use of Agile in IS and how to use it to manage other projects, because we need to deliver value quickly. So I appreciate your perspective there. All right, Dr. Knight, I've got a two-part question for you here. Part one, what is the best method and time frame for including clinical end users in a planning and design process? And then the second part is, how do you get their input and participation when everyone's so busy?
This is I think a perennial problem or challenge for those of us to make sure that we've got all the right folks engaged. And I think at first blush, often people think that they're not interested and that there may not be clinicians that want to give feedback or input. And I think that's not the case. I think in general, our clinicians definitely want to have input. They definitely want to have their voices heard. But I think in some cases, depending on how strong our relationship has been to them, they don't always believe that we will actually do something positive with the information that we collect from them. So I think one of the ways that works very well to get that engagement is to do rounding. And so this may be in areas where we know that people are going to congregate. It may be on nursing units for hospitals. You can often find nurses and collect feedback in that manner. You can ask their leaders where they can obtain feedback. And from the physician's part, there's often either physician lounges or areas where some of our surgical or specialists will participate or hang out in between cases. There's also medical executive committee meetings. And these are areas that if they know that you want to collect feedback and input and you outreach, I've often found that they're willing to give you some feedback. And if you want to dive in a little bit deeper and you can be flexible about the timing, sometimes earlier in the day or just later in the day, you'll be able to get that feedback from people. And I think the key component is really establishing the connection. You will not likely be able to get most clinicians to participate in any regularly scheduled event if the timing's during the regular business day. But if you've established a connection, you can always check either by email or text or phone to get the feedback in an ongoing manner.
Great, thank you, Dr. Knight. Another thing that I always try to keep in mind is don't exclude the naysayers. You need to bring forward the people that might be the squeaky wheels, because if you don't bring them along, they might sabotage it towards the end. So I think another thing is figure out how do you engage those maybe more challenging folks along the way. So I appreciate your insight there. Thank you. Okay, Pam, what do healthcare organizations need to do now, and what do they need to do next? I mean, we're living in a different world. You know, what are your insights there?
So when we first started deploying technologies, it was all about the EHR. In fact, most of our strategies were very EHR or vendor centric. And what I'd like people to do as we're coming over the next few months is really pivot and use a value-driven approach that focuses on the needs of the business and even more so the clinical community, not obviously just the technology. And if you think about those rounds and having those conversations and interacting with those clinicians, one of the things that can make the biggest difference is start to look at the problems, those everyday problems that they're having. I mean, number one big one right now we all know is burnout. We were having that issue before COVID. A lot of people blamed it on the EHR, the administrative load. Are there things that can be done today? You know, how is their clinical documentation and coding working? How are they doing on quality outcomes during this period? Do they have the information they need to look at care gaps of their patients or to address readmissions? How is their patient satisfaction? How is their satisfaction? And what was their experience when they adopted virtual tools like telehealth? Did it go well? Did they struggle? So when you really begin to look at these everyday problems, if we can begin to address that, that'll go a long way in building trust and building that next generation capability as we move beyond kind of today's current state. And one question I would say is, who in your organization is accountable for solving these problems? If you're lucky and you have someone like Dr. Knight in his role, he plays a key leadership role, but you've also got to have other executives that work together to say, we're gonna target this problem and we're gonna do something about it.
Great, thank you very much, Pam. It's really, really big questions that everyone's got top of mind right now, so I appreciate your thoughts there. All right, I'm gonna do another poll here. All right.
Guys, we are going to break this down.
So how do you use consultants to implement new technologies? So again, this is multiple choice. Go ahead and. All right, another few more seconds. We'll close the poll. All right, gonna end the polling, share the results. Knowledge experts, again, it looks like that's the leader, but across the board, lots of different areas. A few folks don't use consultants, you know, lots of changes there, but filling skill gaps looks pretty high. So again, you know, Pam and Dr. Knight, as we go through some of the additional questions, keep these results in mind, please. I'll stop sharing. And my next question for Dr. Knight. Again, how do you select the highest value consultants? What are your thoughts? What are your secrets?
So I always think it's really important before getting started in these types of engagements is for us to define the problem and be specific about the problem. Make sure we understand who the stakeholders are, and those are people I think of as anyone who's going to care about the problem or the solution that we might put into place. Identify the priority, because as you saw, that some of the answers were about accelerating implementation. So for things that that are really important to get done quickly, that would be something that would factor into my decision making, as opposed to something that I've got a lot of time to do. And then really focusing on what I need. So is it that additional expertise? Is it filling in gaps on the team? Is it strategic advice? Or is it something like staff augmentation or transitioning? So I think those are the components that I like to think about, making sure I understand the problem, the stakeholders, the priority and timeline, and then being specific about what I need from the consultant helps direct me to the right resource.
Yeah, great insight. I think knowing what the problem is you're trying to solve can be really helpful, because it will even help you define what type of consultant do you need. You know, who do you need? What expertise do you need to bring to the table to help you move forward? So I appreciate your insight there, Dr. Knight. All right, my next question is for Pam. Again, we've seen challenges in the past. So what are some of the common technology and process challenges that can hinder sustainability?
I think, as one of my clients told me recently, our biggest threat or hindrance is what made us successful in the past, our past success. And I think one thing that COVID has taught all of us is that the way we made decisions historically may be irrelevant in the future, and that we have to use new tools and new skill sets, and probably for everyone to move past this, you know, threat of past success, if you will, really beginning to change the way your organization uses data. Healthcare as an industry has really been good at managing and monitoring retrospective data. And what we have really been good is I'm in my department and I own this data and you're in your department or function, and we don't share a lot of data historically. And what we've got to pivot to and change is beginning to focus on looking at different scenarios using real-time intelligence, and then begin to get comfortable with using predictive data so that we can understand not just what is happening with the real-time data, but what could or will happen with using the predictive data. This is very, very different than the way most organizations have made decisions. What we've also always seen or often seen is that data is used to validate a decision that everybody kind of knew in their gut they wanted to make. But what we've learned, particularly during this time of COVID, is the data may tell us something we didn't expect. We may be surprised, or we may learn by looking at the data in new and different ways. And one of the biggest mistakes I see leaders do is they've got the data analyst team over in whatever corner, and the tendency to toss that over the fence and say, get back to me when you've got the data pulled or you've analyzed it. And they get a data dump, if you will, and there's back and forth and back and forth and back and forth. And what I believe for most leaders today is becoming comfortable not with necessarily crunching the numbers yourself, but knowing what questions to ask, knowing how data can help you think differently, and then kind of beginning to encourage the culture to use data and insight-driven decision making versus just what I call report or scorecard-driven decision making. Because we've been really good at that in the past, but COVID has really taught us that we need to think about the information differently.
Great, thank you very much, Pam. And I agree. I mean, we need to really look at how do we leverage the data we have and how do we fill the gaps with the data we're missing. You know, I see more and more claims data being tied to the EHR data. You get different insights from that. So I think it's a really important challenge. And sometimes you don't have, there's gaps in the data. You won't have every single data element, and that's okay. You can still go ahead and make decisions based on the best information you have at the time. So I appreciate your insights there. All right, Dr. Knight, workflow. This is my bread and butter. I'm a big workflow person. I want to make it easy for providers, nurses to do the right thing the first time. What are the workflow needs of the healthcare provider in the digital era that can best be served to maximize quality, safety, and efficiency?
I'm pretty sure we could talk about this specific question for hours. I think workflow is really where it's at, and as Pam alluded to, what we were used to in terms of data to our clinicians is really about what I did. So it's the ability to look back and look at how I met quality measures, what the outcomes were, the patients that I was taking care of, and how the events transpired in the past, so I could take some lessons and try to apply those in the future. I think there's some focus today on what to do, which is to try to take the lessons and the best practices in the standard work and incorporate those in the workflow. So these are things, some simplistic examples would be things like pop-up alerts or medication alerts that might help guide clinicians to making the right decisions about a prescribing solution or an outcomes-based solution. And what I hope to have in the future is really what to do next. So it's really about thinking about how we need to modify behavior and actions in order to improve outcomes on future patients and populations. And all of these things depend on the workflow. Much of quality and safety historically has depended upon what I tend to call a vigilant strategy, which is trying to get individuals to remember and remain attentive to specific actions that they need to do. And I think, unfortunately, with the advances in technology, there's just a lot more information, not only in the healthcare space, but also in our private lives. And so individuals that are caring for patients are tasked with trying to manage all of the information about their personal lives and needs, as well as the information that comes from the technology, about the patient from other systems and the like. And so we need to make sure that we first understand how people do their work, which is the workflow. And that, Matt, we always talk about go to the Gemba at Piedmont. So it does require some effort to make sure we understand all the steps in the process, and there's also often interactions between other members of the care team with the physicians, and spend time understanding how the work is done, and then think about how we can extend things or simplify aspects of the work through items we alluded to before, the robotic process automation, how data can be presented to individuals, and then how we can inform predictions that make the most sense to the clinicians and present it to them when it makes the most sense to do so.
Yeah, that's great insights, Dr. Knight. I appreciate you using the word Gemba. I'm a big fan of going in and seeing for yourself, going to see where the work happens, and actually looking at what's it like. What are the barriers to a provider or a nurse trying to just get through, a normal assessment? Do they have to jump through the technology and go to 20 different screens to get really important information? It could be a huge barrier. It could cause safety issues. It could cause errors as well. So really good insight. I think it's important to really go and see what it's like in the frontline staff's daily work. So appreciate you sharing that. Again, as a reminder, we do want to have a discussion with the group. So please submit questions through chat. I know there's a couple of questions in there, but we want to make sure that we've got several questions teed up to when we're ready to move over to the Q&A section. So Pam, I'm going to ask you a two-part question. What are some example regulatory things on the horizon that we need to be considering, and how should we prepare for it? There's a lot of unknowns, but what are your insights on what's coming and what we should be thinking about to get prepared for in the regulatory space without spending the whole day? We could probably spend days on this. So this is just to give
2 or 3 sessions
just to give everyone an overview. Thank you.
So I'm going to give more the themes and mention a few of the things that are coming down the pike, just so they'll be on your radar. Probably a number of them are already, but just to mention it. And the interesting thing from my perspective is this is one of the few, and it's hard to believe in this day and era, but one of the few bipartisan areas of agreement in terms of the role of data and technology in the future of healthcare. Put everything else aside where you see disagreement. I think you will absolutely see that the past administrations have supported data and technology across both Democratic and Republican, across the aisle, if you would. So here are a couple of themes that you can pretty much count on. Is one, the continued expansion of value-based care and the importance of data and technology in supporting that. We're not going to be able to get there without it. Also, the increased transparency of the data and the importance of data sharing. And that is, we're seeing a number of states come out with legislation where they're like, okay, you can compete on a whole bunch of different things, but when it comes down to patient-centered data, we are not competing on that. We're sharing that for the good of the patient and for the good of care. We're also going to begin to see a lot of new sources of data that are outside of the control of the enterprise. So when I say the enterprise, I mean health systems, payers, and the traditional controllers of data. If you think about claims and clinical data, that's really only about 20% of the person-centric data that's out there. So that there are a lot of other sources. So if you think about the legislation, some that's already been announced, some that is going to be coming down the pike, we're going to see changes in HIPAA. HIPAA is a very old law, and everyone pretty much agrees it needs modernization. And what form that will take, there are a lot of different theories. The 21st Century Cures Act, a lot of the announcement regarding interoperability and information blocking kind of got lost in the early days of COVID because it came out in March of 2020. But over the next year or so, we're going to see a lot more requirements for both providers and payers in terms of sharing information and exchanging information. The other thing that's going to be interesting because of apps and this move toward mobile, we're going to see a lot more consumer mediated data. And that will, as I mentioned, that'll be outside of the control of our traditional healthcare ecosystem. And so we will probably see the FTC getting more involved in regulating that information and how that information is shared. FDA is going to be involved with digital therapeutics, which that's about data and using that for therapy. Start relaxation, which was announced earlier, is going to do a lot to support investment in care coordination and data exchange. So a lot of these regulatory changes are really converging in that they are all pushing toward more data sources, more data sharing, and more coordination with the use of that data. So that's just something that is pretty much something you can count on.
Great, thank you, Pam. So, Dr. Knight, COVID and the pandemic has actually had a huge impact on how patients access and interact with the ever-changing healthcare delivery model. A good example, my parents are up in New York. They were both of age to get their COVID vaccine. It was so challenging. I was like their personal consultant, working nights trying to schedule their COVID vaccine at Walgreens up in New York. I mean, and my mom's actually pretty tech savvy. My dad, not so much, but it was a challenge. And so, what's the best approach to educate our patient community in learning the changes to the healthcare model, the healthcare delivery model, how we access it, how we get scheduled, and how do we, align ourselves with different providers?
Matt, you are not alone. I've heard that same story from many other people about trying to convince one or both parents to participate in getting vaccinated, or that if they were ill, going to seek healthcare during this time. So I think on multiple domains. From what I've observed, really what we need to do is equip the treatment team, the physicians, with the information about the healthcare changes and ask them to talk to their patients about it. I think the physicians can talk to their patients about what we're doing differently. And I think there's an awareness for most patients about the consumerism, patient experience focus. And so these things are not a huge stretch. They'll be familiar with things like Amazon and Uber and other technologies in their personal lives. So I think as we advance in certainly the virtual care space, these things will make sense to provide access. And we do know that even pre-pandemic, when we looked at the patient portal engagement, there's a lot of benefits. These were created so that patients would have access to their own information. They can simplify some of the check-in process for the patients and save time at the doctor's offices, can help the doctors gather information about the visits in advance or validate things that are in the record. And with the Cures Act that Pam mentioned, there is a greater level of transparency, which helps build trust in healthcare. All those things are accessible through the patient portals, but the primary reason patients sign up for is if their physicians ask them to. So we really need to include the care team and engage them in helping us communicate to their patients who they've spent, really that relationship's based on trust.
It's 1 o'clock.
So Sorry for my reminder alarm there on the computer, but that relationship between the healthcare team and patient is based on trust. And if we gain the trust of the clinicians and the changes that we're making to improve the healthcare system, they can share that information with their patients and help engage them as well.
Great, thank you very much, Dr. Knight. And I appreciate your computer telling you what time it is. That's your way of leveraging data and technology. My young boys know how to talk to Alexa and ask them to put on their favorite cartoon. So at a young age, they're learning more and more about leveraging data and technology. So I think we have to, be prepared for that. We've got this generation that has grown up with it. So we're going to need to pivot as well on how we are able to provide those services, taking advantage of the data and technology that's available. All right, I've got a couple more questions and then we're going to move over to Q&A. So again, submit your questions in the chat. We'll also let you unmute in a few minutes to ask your question live if you'd prefer. All right, this question's for Pam. What are some pitfalls to avoid when it comes to leveraging data and technology? I'm sure you've seen a lot with some of your clients. You don't have to share names, but do you have any examples to share of things not to do when you're trying to leverage data and technology?
Yes, I think one of the biggest questions we see, healthcare is about organization charts. If you haven't noticed, everybody likes to have a perfect org chart with everybody in a little box. And what we often see, particularly around the data asset, is arguments around who's going to own it. Does finance own it? Does the clinical team own it? Does own and own and own? And what we've actually found is every part of the organization needs analytics. They need data. And so what we've often seen is having a nice core team that makes sure your tools are being used well, your methodologies work, your education is going well, but then you have almost a hub and spoke model where different parts of the organization bring in their specific data needs and data expertise. So they all work together, but they're also able to support their individual needs. And so the biggest problem I see is bringing politics into data. And since nobody has any politics in any of their organizations, I'm sure, I just would make that as a few of my clients have had that, but certainly none of yours. So.
Great insights, Pam. Data governance is a big topic. I think we're still learning. We try something and it works, part of it doesn't. We throw that out and start over. So really important, I think, to have a strong data governance model to know how to navigate some of these decisions on, what tools do you need, who owns it, who's going to maintain it, et cetera. So great insight. All right, Dr. Knight, I know because I'm here at Piedmont, but I'm curious. I don't know the answer. I do know it happened, so I'd want to hear your insights. What was Piedmont's approach to launching telemedicine in the early weeks of the pandemic? And that got turned on really quick. I was really impressed, but I don't know the whole story. So what can you share?
Sure. So I'll say at first we were lucky that we had some structured roles and some familiarity with it. We've had programs on the inpatient side at a few of our different hospitals related to the ability to extend specialty services to some of the hospitals. We also had a partnership with Georgia, a partnership for telehealth that also allowed us to extend reach for transplant patients. So that starting point was beneficial to us. And I think for us, what the key thing we were recognizing is that with patients getting sick and the risk of providers getting sick before vaccines were available, that we needed to try to keep people safe and also make sure that we provided an avenue for them. And we needed to be as quick as possible about it. So our first approach was to look around and see what tools we had. And we found that we could use a platform that we were using at the time, WebEx, was secure enough for us to be able to extend that to patients. And as we started rolling that out, we knew that it was going to require a bit more of an operational lift than what any ideal solution would be. But seeing that we had most patients remote and suffering at home without desiring to go and seek healthcare, it would be better to be able to provide the virtual care than anything else, and we would be able to accommodate some of that additional operational lift. But while we were doing that implementation, we knew we needed to plan for version 2 and version 3 until we can get to a steady state, because we were aware of the fact that our healthcare team would finding it increasingly difficult to maintain a significant operational load. And I think this allowed us to go from 0 to version 1 in about 5 days, to version 2 in about 2.5 to 3 weeks, and to a more stable platform, I think about 4 or 5 weeks.
Yeah, that's great. It was really impressive. The team that launched the telemedicine so rapidly and leveraging things that we already had. So I think that was really an important piece of it, to get it started, knowing that it wasn't the perfect solution. It wasn't the end solution. It was one that was going to help us get through. So I was really impressed and appreciate all the hard work of you and your team and providing that service for our patients. So Bruce, I know there's a few questions here in chat. I want to hand it over to you to ask a few of those questions, and then if people want to open the mic, you can explain that process. Thank you.
Thanks, Matt. Yeah, the first question we have, with the negative impact of COVID to revenue and viability for healthcare providers, do you see a move to greater risk and employer direct contracting as seen in other markets to manage revenue? And the second part of the question is what technology changes will be needed to survive in this new dynamic?
I can address that. So absolutely, we see that COVID may have the unexpected impact of accelerating some of the move to value based on the fact that fee for service just really wasn't there for us during a great deal of the pandemic. But beyond that, if you think about a platform that is layered on top of or in addition to your EHRs, that make sure you're sharing data, interoperability, analytics, care management, and consumer and patient engagement. Those are really the capabilities you need. But I'd suggest that you don't think about it like the old days. The old days is your IT department would implement a application within your enterprise. Today, it's much more about the extended enterprise, and we're going to see more and more organizations either partnering or through some of the consolidation that's going on, they'll be able to afford more. Or the other interesting thing is we're seeing some of these solutions, interestingly enough, actually provide an ROI, and that things that you had in-house, capabilities that you were building internally, you can now do in the cloud, you can now do with your partner, and so you don't have to build out the resource. So in effect, the business case is there to move to some of this next generation, as opposed to the old days where we had to go buy an application and implement it within our enterprise. So more partnering, more community-based people working together, more collaboration, and ultimately more solutions that are not dependent on one organization to run.
I think that's a great answer, Pam. I think one thing I would add is I think related to what you're talking about is really just that you may have to help me clarify my intent, but we used to do a lot of long range planning. So if you wanted to do something, you would do something thinking that you need to have 2 or 3 years to get it stood up. And that's where the partnership Pam reference is important. I don't think that's really tenable anymore. I think if you need to advance technology, you need to look at what you need in place to get somewhere in 3 to 6 months, and then think about almost the flip. What are the long-term implications if I take these next actions? instead of trying to have a multi-year roadmap for some of these things as the primary format.
And analytics is a perfect example of that. So you don't have to roll out this big bang analytics initiative. We in fact talk about agile analytics a lot. If you can take it, learn, do a small, very almost minimal viable initiative, then move to the next, then move to the next, and you grow and the organization learns. It's not like the old days of having to implement, taking 18 months to implement an application.
Great. Thanks, Pam and Dr. Knight. The next question we have is how soon before we see TJC or CMS and others require technology-based modalities as a standard of care and demand metrics? Any thoughts on this?
Dr. Nye.
So I think there's going to be some time. I mean, I would imagine, because I think we're not at a place where things are standardized, you know, with some of the advancements in the Cures Act, at least I'll say a line in the sand. So things about the transparency movement, there's been some legislation recently that requires additional transparency in pricing, as well as in patient information, health information. Pam referenced the HIPAA laws that are going to be changing, and then a component of interoperability is coming this spring. So I think those are the kinds of things that will get a lot of us ready, but I think it'll be a little bit of time before we actually see that manifest at the TJC, although some of these changes are conditions of participation in terms of the automated communication of admissions, discharges, and transfers that's due in a couple weeks.
Okay, thank you. Next question we have, level of trust in our healthcare system by the public is at an alarmingly low level. What truly innovative approaches can our very traditional health systems and medical practices deploy to engage patients and their families to improve health? And do you envision a strengthening of private healthcare and public health systems partnering around data as a way out of this dark woods?
I can start on that. We're actually finishing up a project for one of the states in the Northeast on the use of data. And historically, their statewide databases were all very health system and payer centric. And one of the things that's really come out of COVID is the need to partner with public health to have person-centric data that goes way beyond the clinical and claims data, but gets into social determinants, gets into behavioral health data, gets into even some of the factors that may impact a local community that go in more depth. So certain things around different agencies that the state has access to, such as education or prison system or on and on and on. And so if you think about person-centric data and following that patient wherever they go, including their information that they create in their Fitbits or their home monitoring or whatever, that's going to open up a whole different world for all of us. We see probably there are going to be a number of initiatives to grants and other funding to support those efforts. And what we would encourage organizations to do is, because so much of our data has been entity specific or provider specific, almost go through a visioning process of what does person-centric data mean to us? How does, if we have data from not just what we have, but from other places, how would that change how we'd interact first with a consumer before they show up at our doorstep, and then once they become a patient with a patient? And so just thinking in those terms and having conversations at this point can be very, very helpful.
I think I will leave. I think you did a great job answering that part of the question. So I'll focus in more on the trust piece. I think that in many ways, this is behind the curtain. Healthcare's been behind the curtain for people that have predominantly interacted with the health systems as patients. And so there's been some transition with that over time. You know, I remember that in the beginning, it was only really physicians that had access to the medical books, textbooks, and medical classes and curriculum. And then over time, you know, almost all that information is available in public libraries or on the internet. And so the relationship between a patient, certainly with a significant chronic illness, evolved from the physician being the expert that had all the data about the illness, to the patient being an expert on the illness and the physician being a guide to help with the decision making through the healthcare process. So I think the biggest thing that health systems and healthcare providers will need to do is demonstrate that transparency about that patient-centered data, as well as many of the processes surrounding patient care.
Great, thank you. Next question. What are some of the tools you're using at Piedmont or Maestro to transition Epic data to predictive algorithm-based problem solving, or the early building blocks to go from EMR to intentional data usage?
Piedmont want to start?
Sure. So we have a lot of different maybe footprints in that. So some is with some of our software partners, where we've tested algorithms. One of the recent ones that we've used, been focused on, is related to predicting sepsis and trying to reduce some of the workload of our nursing teams by using algorithms to identify patients that are very likely to have sepsis, and then presenting the information. So rather than using the healthcare providers for the first tier of screening, use evidence to identify patients that are most likely to have sepsis, and then present those findings to the care team to go and then see the patients. So that's kind of one of the things that we've been focused on, more of the prediction algorithms. We've got some work, I think Matt referenced earlier, to try to understand systems where we can feed in data and then define the algorithms as a result of the data and make some predictions there. We're pretty early into that journey. And then I think the third element that we are looking at and have been doing over the last year is related to partnerships with vendors that have some tools that help assess imaging and risk for certain types of ailments related to that, and a way to help prioritize work for some of our clinicians when the technology identifies higher risk based on certain images in the neurosciences space.
So I'll just answer a little bit more at a category of things to think about. All of the EHR, or the majority of the EHR vendors, Epic, Cerner, most of the major ones, have some types of tools that you can begin to work with, analytics tools, algorithms, etc. There is it's like the wild, wild west out there right now in terms of predictive modeling companies and da-da-da-da-da. And I would say be cautious in that you got to know what problem you're trying to solve and not trying to do a silver bullet. I would say there is a category that we are tracking and we're monitoring called care management platforms or population health management platforms that integrate multiple of these capabilities: the interoperability, the analytics, care management, and patient engagement. And there are probably, I'd have to look back at my notes, but probably a good 8 or so major players in the country. You've probably heard of a lot of them. And then beyond that, when you really start getting into very, very targeted, the use of artificial intelligence, machine learning, I mean, you've got a work process in our industry, and there's a tool out there that somebody will sell you to work on that in that space. Everything from HR to revenue cycle to clinical. I mean, we could just go on. And so I think this gets back to, while you don't need a full-blown, detailed, 5-year strategic plan around data, I do think you need some type of plan that goes beyond the traditional IT focus on the EHR and other applications, to think about, what does data mean to us? Where are we in moving from looking at retrospective to real time to future oriented data? And what do you need to be learning as an organization? Because there are a lot of things you can do with demonstration projects and kind of experiments without just going and buying and partnering with another vendor. Not that you might not want to do that, but sometimes it helps. One of my colleagues talks about sneaker wear. Sometimes it's good just to do it in a hypothetical or an example, to see how you would use some of these tools before you run and go buy the next vendor solution. So vendors out there, don't get mad at me for saying that, but sometimes we jump into those thinking they're going to be a silver bullet, and they're not.
All right, we have another question in chat. The world and technology continue to advance with virtual care, smart apps, and remote workforce. What is your strategy surrounding cybersecurity, protecting the consumer's information, and of course the health system?
Anybody, I can say you have to balance. I have been to places that were so locked up, like Fort Knox, that they couldn't provide clinicians information they needed to take care of patients. On the other hand, I've been to places that should have had a little more security. And I think there is a balance between the legal and compliance issues, the IT security issues, the clinical care process issues, and the business issues. And you need those executives at the table together, making sure that, okay, we might give up a little security to be able to do these things with our external partners, or no, we're going to put security around that. So it's complex. There's not a one size fits all, but I do think it's a multi-pronged and multi-perspective decision process.
Dr. Enright, did you have anything on that?
I think the only thing I would add is that I tend to take a different approach. We are very, very focused on cybersecurity. Obviously, healthcare is a highly targeted industry. And I think the solutions we look at, we try to see how they can meet the minimum security requirements. And if need be, we can get into a conversation about risk versus value. But I think most players with depth have an understanding of the minimum requirements they have to ensure, to meet health system requirements. But we're more on the stricter side of things.
Great, thanks. I have another question in the queue, and then we probably have time for one or two more questions. So if you have a question, feel free to ask it in chat or unmute yourself and ask the question directly. Let's see. What are patients expecting different from providers as it relates to data and technology?
You want to start, or?
Sure, go ahead, Pam.
Well, so I think most patients think about using Amazon or using their phone, and they want that kind of convenience. And that's probably about as far as they take it, unless they've got a chronic condition that, or even an acute condition, and then they want access to information. And they don't want it to be difficult, and they don't want a lot of barriers. And so it's always the patients with the most difficult situations that probably test the boundaries first, because they need it for their own health. So That's at least a high level answer. Dr. Knight, do you have a thought on that?
Yeah, no, I agree with you. I think there was a period of time where we were not focused on the consumer experience related to technology, but healthcare's gotten eclipsed because the accessibility to travel, at least in the old days, a year ago, order online, those types of things provide an experience that is well beyond what most of us experience interacting with healthcare. So I think we're in some ways trying to play catch up. And at Piedmont, I can say we've got to focus on trying to make the experience hassle-free for patients using technology. But it is a significant effort to get there.
Great. Well, thanks, Pam and Dr. Knight. We don't have any other questions in chat. So Matt, I'm going to turn it back to you in case you have any concluding comments, and then we'll turn it to Trent to wrap us up.
Yeah, thank you, Bruce. I just want to extend my thanks to Dr. Knight and Pam for this great discussion today. And Bruce, again, for your assistance in keeping us organized. So I appreciate everyone's time. And I'm going to hand it over to Trent. Thank you.
All right. Hey, Matt, thank you so much. Really appreciate your engagement and helping to facilitate and put this program together. I know you and the team on our programs committee always look for on-topic points that we want to get across, and this is very, very timely. So thank you so much. And then certainly, Dr. Knight, Pam, your insight has been tremendous. I mean, you look at, again, just over the past couple of years and how much we have really tremendously leapfrogged where we were years ago around how we leverage technology and how we're able to actually leverage technology to improve outcomes, which is obviously first and foremost, but also how we're leveraging technology around the payer side, the physician side, as well as Dr. Knight pointed out, the consumer side of the equation as data becomes more and more transparent. So really appreciate your insights. Thank you for spending the afternoon with us. And as a matter of wrap up, really want to again thank the sponsors. We don't put on events like this without tremendous support of our sponsors. So thank you again to our sponsors. Thanks to ACHE. Ricardo, really appreciate your support and our ability to allow face-to-face credits for our membership. And then really just a big thank you that goes out to our membership as a whole. Your leadership across the great state of Georgia is just tremendous, and we see it every day. And thank you for engaging in a deep way to get better. And certainly you're on this call today because you want to get better and you want to get your organization to a different level. So thank you so much. And don't forget meeting evaluation. We love to get your feedback. So we get a lot of good feedback, but we also look for that critical feedback where maybe we can host things a bit different or create more of a dynamic. I think Matt and team did a great job of keeping it interactive today. And certainly I think we learned a lot about each other through that process. So with that said, I'll turn it back over to Ricardo. Thank you, everyone.
Thank you, Trent. On behalf of ACHE, I want to thank our chapter leaders that planned today's session, the moderator and panelists, and all of you for your participation today. Please complete the evaluation, which is open for 1 week. The direct link is in the chat box now. You can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the Helpful Links section on the right side of the screen. From there, click on the Access My Courses link and you'll be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who has attended today's session in its entirety will see their 1.5 hours of face-to-face credit posted to their My ACHE account within 2 weeks of this session in the My Education Credit section. That concludes our session. Today's program is copyrighted in 2021 by the American College of Healthcare Executives, all rights reserved. Thank you for attending and be well, everyone.